tonight's program, we have the MS Advocacy Hub. And my name is Stuart Schlossman. I'm president founder of MS Views and News. And tonight we are sponsored by Bristol Squibb and Biogen. We want to thank them for providing their support. And of course, we have Dr. Samowitz. And Dr. Samowitz is a urologist in South Florida. Okay, Dr. Samowitz is not just a urologist, but he does many things that people don't recognize that a urologist does. It's not just about bladder issues. It's a lot more complicated than that. And Dr. Samowitz, firstly, I want to thank you for being here. Next, can you tell the audience why it's more complicated than just the bladder?
What you mean? What is urology?
Yeah, about you. I want them to know more about you and what you do.
Oh, okay. Urology does focus on, of course, urinary problems, the kidneys, bladder, but we also are involved in the genitalia, more so in the male, but also my subspecialty is in female pelvic medicine. So that includes obviously the female genitalia. And of course, that leads us to our topic today, which is sexual dysfunction.
Yeah, sexual health in MS, all right? So what I want to let everybody know, though, is this is going to be a very interesting topic tonight, all right? You know, it's not for the person who is, you know, afraid to talk about what's going on with themselves. Actually, I really do hope that some of those people are online tonight, so you could actually see that it's not only you that this affects, all right? It affects women certain ways, it affects men certain ways, all right? But there are many that are afraid to talk about their sexual health or their intimacy issues that they might have. They're bashful or they have other things going on. They don't even know how to talk with their own, you know, significant other or their healthcare team. So, you know, we want to bring out some of these things tonight. We do have questions that I'll be that we have that I'm going to be speaking with the doctor about. And if any of you have any questions, please use the box that's on the top of the page, the orange box, and just click on it and type in your question as we're talking about it, or any questions that you might have that you would like to ask about. You could type them at any time. We also have a couple of handouts, all right? And when I get to certain parts, certain questions that I do have for the doctor, I'm going to say that that's in handout 1 or handout 2. We wanted to have a lot more, but with internet problems and so many other things going on these days, we just had some issues that we couldn't work with that today. And they were not sexual, all right? But we still had problems. All right. So to begin everything, I want to ask the doctor, though, why is it that makes sex so difficult, not just from being a doctor, but just in general? I mean, can you tell us, like, what it is that the world knows or doesn't know?
Well, obviously, this is a very huge subject because we're very preoccupied on our minds. They've done studies that have showed that men think about it almost several times every hour. But the reality is that it involves multiple facets of what it means to be human. And it's not just psychological, it's emotional, it's hormonal, it's vascular, it's neurological. So it involves so much of our being, our essence, and it's very complicated because human beings are so complicated.
Okay, thank you for that. All right, next we have a big, I have a little question that's going to create a very large answer, right? And for those that want to follow along a little bit, they're in our first handout, all right? And it's 3 different pages of information. But doctor, can you please, can you define sexual dysfunction in multiple sclerosis?
Well, the definition of sexual dysfunction is just the difficulty experiencing satisfaction in sexual activity. And that applies not just to multiple sclerosis, but to any chronic illness. And there's different phases to the sexual response, and we try to break it down to try to figure out what phase is the problem for that particular patient. So there's excitement, plateau, orgasm, and resolution. Then we break down the 4 categories of sexual dysfunction so that there's the desire disorders, the arousal disorder, orgasm, and pain disorder. Desire disorder is when you have little or no interest in sexual relations on an ongoing basis. Arousal disorder means you're emotionally in the mood, but your body just is not into it. Orgasm disorder means you're emotionally in the mood, but you have an inability to climax that leaves you frustrated. And then the pain disorder, obviously, is pain during intercourse. So with MS patients, obviously, we try to break that down and try to figure out what level it is that they're primarily is causing their problem.
So what treatments do you have for each of the things that you just mentioned, each of these different categories? How do you work with patients, male and female? And I guess obviously there's different answers. So if you can, please grill us or tell us about everything.
Well, I think before we get into treatment, we ought to try to figure out where the problem is. And one of the ways that we try to do that, there's a questionnaire that I've included that will help us to identify for the patient. And then what?
Excuse me 1 second. That questionnaire, everybody, is the second handout. So that's what he's referring to right now. Sorry about that.
That's sort of the first step, perhaps, in trying to figure it out. We also have similar questionnaires for men with erectile dysfunction, and we give it a score. I didn't include that. That's a generic a form for that we use in all men. But this particular handout, this particular questionnaire is specific to the MS patient. And when what we try to look for is it a primary, secondary, or tertiary issue in the MS patient? Primary effects are related to impaired genital sensation or decreased sexual drive. Secondary effects focus on fatigue, bladder problems, spasticity, or muscle tightness. And tertiary effects are related to the psychological distress, overall well-being like depression, and feelings of negative self-image. And so once we get sort of focused on where that issue is, then we can address it. Some cases, we would address it through a treatment that is hormonal. Sometimes it's a mechanical issue that we could try to help the patient, such as lack of lubrication. Sometimes it has to do with concerns about incontinence and urinary issues directly. And then, of course, there's the more emotional, psychological issues, which we sometimes will refer on to a sexual health therapist.
Okay, so something that's come up, I've heard many times over the years, and that is that if a person has an issue and that person seems to carry that same issue from one intimate moment to a next, and afraid that, maybe not saying that the person is afraid, but concerned that the same thing's going to happen over and over again. For instance, a woman who is having problems reaching climax and is very concerned about that, and it seems that she can go from one episode to the next without reaching climax, though enjoying everything that she's doing, during the act of A to Z, all right? But just is not able to reach the moment of climax. What can you say for a person, male or female, that reaches that level and seems to be having that problem?
Well, we went right to the most difficult questions, which is the female climax is the hardest part of
okay,
of
we'll start with
this.
the male. Let's start with male, and we'll backtrack. All right, we'll back into it.
Okay. Well, anyway, the female climax is more elusive than the male, obviously, and it requires. A lot of times we don't always know. We don't have a lot of management for the female patient that has difficulty reaching climax. There's not many different, because there's some medications that we've tried for mostly arousal. They work mostly on arousal. Reaching climax is a more difficult issue, and especially in a patient who might have some neurological effects, it's going to be a more complicated matter because there's decreased sensation and so on. But I'd rather, if you don't mind, I'm going to try to work from the simple, basic stuff, and then maybe build to the more complicated.
I don't mind. Take it
Good.
away.
So when we talk about, let's say the male, it's a much simpler matter because all we really have to do for most men is help them to achieve the erection. I mean, that's really the bottom line. There's of course issues with arousal and so on, and these men reaching climax. But when it comes to the male, it's more simple and mechanical. Help them to achieve erection, and that's why Viagra and Cialis and all the others are such big products, is because they made a huge difference in us helping these men in a simple manner. So there's of course the sildenafil and tadalafil, which is the generic names for these medications, and they work only in about 60% of men. So there's a large number of men that we don't have good treatment for with the pills. We have to go to more advanced treatments. Some of these men will have to learn how to do self-injection with a vasoactive medication. They inject the penis prior to intercourse. It works 90% of the time. It'll work in patients that have neurological disease, but there's a big psychological hurdle there. Obviously, it's a tiny needle. It's more psychological pain than physical pain, but it does work.
Right.
There's a suppository that can be pushed up into the urethra that melts, but it's still very expensive, and it doesn't work as well as the injection. Vacuum erection devices are not very satisfactory. They draw blood into the penis. You then place a rubber band at the base of the penis, and it maintains the erection for about 30 minutes. It's not very sexy, is the bottom line. And then finally, there's surgery where we put in an implant. There's both the inflatable type and then the malleable, which is something you just bend up when you want to use it, and then you bend down when it's not in use. And then the inflatable is a device that you can pump up inside the scrotum and put fluid into the cylinders that are in the penis. And then when you're done, you press a button under the skin and it goes down again. So that's sort of the basic management of men with erectile dysfunction. When it comes to hormonal, we get into usually testosterone. Testosterone gives a permissive effect for erection, but it doesn't necessarily cure most erections. Most of the men are having neurovascular problems, and therefore the hormones are not going to help that. But if they have a low desire, if it's an arousal and desire issue, hormones like testosterone usually do help. And it's tricky to give testosterone because it is a controlled substance. There's a new pill that just came out, but it's very expensive. And for the most part, we have to use injections or the skin or some other means to increase testosterone. I don't like giving men testosterone because it inhibits their body's ability to make their own. And sooner or later, they become dependent on it. The testicles atrophy and they no longer are able to produce their own testosterone. So I use sometimes a medication called clomiphene, which is off-label, but it gives the patient the ability to make more of their own testosterone. And I feel it's more natural. So we use a lot of clomiphene in my practice. The female is a lot more complicated. I guess we can get into that if you like, but I don't want to just monopolize the.
Yeah, I was going to say, I got some questions for you based on with what you're talking about right now, and thank you for that. But yeah, we're going to get into the female issue in a minute. Don't worry, ladies, we're getting there. All right. So question that you're saying about the testosterone, if people are using testosterone too long, that you can't produce your own testosterone, and what happens to the body, for those that don't know, if there's not enough testosterone in the body?
So testosterone gives men their sex drive, but it also kind of gives them a sense of well-being, their je ne sais quoi. They want to get up and do things. They want to get off the couch. It gives them desire in a lot of ways, and so they feel better with it. It also increases muscle mass. It increases the blood mass too, which is sometimes an issue. But it also gives you the ability to, you need it for your bones as well. It's actually good to have normal testosterone levels so you don't develop weak bones. And of course, when patients have chronic illness like MS, they're more prone to having decreased testosterone. So a lot of my MS patients are on some kind of a testosterone supplement or testosterone booster to keep them feeling better and keep their muscle mass up.
Okay, thank you for that. So we hear many times about men turning over, getting over 50, which hopefully we all get to, right? I'm way older than 50 already. I don't like saying it, but I am. All right. And so your T levels go down when you go over 50. And so for those that are over 50 and are feeling very sluggish, tired, or not wanting to do things, is that like an indicator that their testosterone levels might be low?
It could be. Unfortunately, there's sort of this marketing to make men think that this is the fountain of youth, and it's really not. It does make some men feel better, though, and it's certainly worth a try. But we first have to test the patient to make sure they truly are low. What happens as we get older is our total testosterone levels go down. But the most important part of the testosterone is the part that's free in the blood, the bioavailable testosterone. And what happens is most of your testosterone is bound up into protein and is not available to your cells. So there's a little bit of a compensation where as our testosterone levels go down, the proteins, mostly the sex hormone binding globulin, SHBG, sex hormone binding globulin, most of that goes down as well. Therefore, there's more free testosterone available to the body in the older patient. So it kind of counterbalances. Nevertheless, we find that patients do lose their testosterone. Even their free testosterone does go down as they get older, and we can supplement. Patients can do injections. They can do a gel or cream, or I could put pellets in that last 3 months. They get placed under the skin. They're made out of a soy protein, and they slowly dissolve over a 3-month period. I did mention earlier there's a pill that just came out, but it's going to be expensive. It's only been out about a year or so. And then there's some long-acting injections and then short-acting injections. Usually most men opt for the short-acting injection because it's inexpensive.
Okay. So for all the ladies out there, if your significant other is just not responding well for you right now and they don't want to be sexually active, maybe this is a reason. Yes or no, doctor?
It can be. It can be. But I don't want patients to misinterpret that this is going to fix their problem because it doesn't know. It can, and there are many instances it does. But because we're talking about something as complicated as sex and relationships and so on, I have patients that are disappointed that they don't see an improvement, even when their numbers go up.
Okay. Again, ladies, before I get into the female things that are out there with sexual dysfunction or whatever, we're just still talking about the men right now. And Doctor, what can you tell us about the males, though, that are their inability to reach climax, and what could be causing that? I've heard you speak about retrograde climax. Can you tell us what that is? And, the guy that might actually feel like he had an orgasm, but there's no liquid to prove it. So what can you talk about?
Well, the male orgasm is somewhat separate from ejaculation. I mean, you can still have an orgasm without ejaculation. There's actually several phases. There's the emission where the fluid gets into the urethra, and then the ejaculation when it gets forced out. So, but the orgasm actually occurs in the brain. So it's a lot more complicated. There's a dopamine release, and it's a complicated thing that goes on in the brain. So you can have orgasm even without erection. It's possible. But as far as the ejaculation, and what you're describing, I think, is retrograde ejaculation, because there's orgasm and there's climax and then there's ejaculation. But you can have a retrograde ejaculation. Primarily, it happens in men that are on medications that we use for the prostate. There's a lot of medications out there for enlarged prostate called alpha blockers. That includes Flomax, Tamsulosin, Cardura, Hytrin, Uroxetrol, Rapaflo. These are our most effective medicines for enlarged prostates and the obstructive symptoms of enlarged prostate. Unfortunately, a lot of them will have retrograde ejaculation. There's two sphincters. There's one that's an internal sphincter that's above the prostate, and then there's another sphincter that's below the prostate. The sphincter that's below the prostate is really the main sphincter that we think about that holds the urine in. And when you have these medications, they relax the internal sphincter that's near the bladder. So when the semen comes down through the ejaculatory duct, and most of the semen is coming from the seminal vesicles that are directly behind the bladder, when the semen comes through the ejaculatory duct, it's going to take the path of least resistance and it's going to go backwards up towards the bladder instead of coming forward. There's a reflex that during erection, the sphincters tighten to prevent urine from flowing out, and that's why when a man has erection, it's hard for them to pee. But with these medications, it relaxes the internal sphincter, and so you get the retrograde ejaculation.
Gotcha.
There's also surgery. When men have surgery for their prostate, there's one called a TURP, transurethral resection of the prostate. It used to be the second most common operation in the United States. It's still a great operation for the prostate, but it can cause retrograde ejaculation because you're removing that internal sphincter again. And then, of course, men that have had radical prostatectomy for surgery don't have a seminal vesicles, don't have a prostate, so they don't produce any fluid anyway.
Okay, thank you for that. So what happens physiologically to the male penis when there's a desire to ejaculate or urinate at the same time? I mean, how does the body know to take this and make it this so they could pee?
How does the body know? Okay, so there's reflexes. There's a reflex that tightens that internal sphincter with the erection, and that way there's less likely urine to come through. But that also, it's really the external sphincter that I mentioned that's below the prostate that controls the urine. So most of these men still can have a climax without leaking.
Okay. And what do you suggest for a man who loses penile sensation during a sexual encounter because of their MS?
This is more related to the MS, and I'm not sure if there's anything that can be done to increase sensation.
Okay.
I'm not sure there is. I mean, that's sort of.
I don't know. I mean, we hear from many about talking about toys, talking about doing this, doing that, all different things that you could possibly do to try different things. But, we just don't know if there's something medically available to increase sensation for the head of the penis,
Well, I can't say there's anything medical. When we have patients, let's say, that have a spinal injury,
right.
They can still have erections, but they have no sensation. And the way that we can help these men to, let's say, have erection or even a climax is we use vibrators on the genitalia. And that will give them a erection and even a climax, so that if they want to have, if they have infertility issues, we can sometimes get a semen specimen from them that way.
Okay, thank you for that. Let's get into talking about women now. All right. All the ladies are like, finally, you're bringing up subject that we want to hear, right? And by the way, everybody, we got a good amount of men on here tonight, and though we do have a lot more women. All right. So firstly, again, I want to let everybody know, you could ask any question you want. Type it in. You will not get your name mentioned tonight. This is not the program for me to mention your name, all right? But I will be able to just read off your question to the doctor, and he'll be able to answer. So going into this a little bit more, can you please tell us or give us suggestions to increase desire for women who have a low desire? I mean, we spoke about men with the low T and everything else, but with women, I think you called it hypoactive sexual desire disorder. Plain and simple, ladies, you have low desire. For those who have low desire, that's what we want to know about, right? What does the doctor have to say about this? What can he do for you? Not directly.
Keep in mind that the ladies are much more complicated. I don't have to tell anybody this. It's we all know
They know
this.
it all already. They already know it all. Doesn't matter what
This-
you're going to say. They already know the answer.
You know, for most of us males, the female is a mystery, and it will probably always remain so. But what we know medically is that you have to keep in mind that the female sexual dysfunction is only a problem if it bothers you. If it doesn't bother you, then it's not a problem. I mean, we don't want to create issues, but because there's so many possible symptoms and causes, the treatment can vary. It's important for you to communicate your concerns, and that's probably the biggest hurdle, is getting these patients to talk to their doctor, talk to their gynecologist or urologist about this, because for the most part, they don't admit to having any sexual problems. um, and then of course, women much more than men benefit from the combined medical and talk therapy, basically. As I was intimating earlier, men are much simpler in that we just have to, it's like construction. We just got to build an erection and they're usually happy. That's what they are interested in. Women are much more complicated. So the non-medical treatment for female sexual dysfunction is the talk and listen, open communication with your partner. Of course, practice healthy lifestyle habits, limit alcohol, be physically active, increase, do things that increase your stamina, elevate your mood, enhancing romantic feelings, learn ways to decrease stress and to be able to focus on the sexual experience, to be involved, be present in that. Seek counseling. Sexual health therapists are available. I often refer patients for sexual health therapy. It's usually a couples therapy. They'll do it online with you. You can avoid the embarrassment of having to be face-to-face or in the same room with them. And it works quite well as a telehealth. And I'd be happy to share some of the sexual health therapists that I use. And they're very good. They do help patients. But more so the female than the male, obviously. But it's a couples thing because often relationship issues complicate this even more. Using the appropriate lubricants, a vaginal lubricant for any females that are having any discomfort with sex should be used. And then, of course, there's no harm in trying a device. Arousal can be enhanced with a vibrator, especially around the clitoris. And to increase their ability to achieve erection on their own means that they're more likely to have a climax with their partner, so that they kind of learn what they like and to use that. I'm not going to get into the sexual therapy because I'm not trained in that. I don't know if they talk about using fantasy, using sensate focus and other things. I don't really know about that too much, but I do refer them on. When you get into the medical aspects, we do talk about estrogen therapy. There is some benefit to using some of the female hormone, either vaginally or orally, to help enhance lubrication. It increases vaginal tone and elasticity, increases blood flow to the vagina, especially in a woman who's postmenopausal. Only in postmenopausal women would we consider that. And but there are some concerns about this. There are some risks. Taking birth control pills, taking estrogen is got some potential problems. And again, I would refer someone to a gynecologist for that, because they will give very low doses, but they'll add some progesterone to it as well. There's some new medications that have come out that I don't have a lot of experience, but I'm going to mention them anyway. One is Osphena, Osphena. This is again for patients that have difficulty with lubricating. It's non-hormonal, but it will increase the lubrication and helps with the atrophy, the atrophic vaginitis that happens with aging in the postmenopausal female. We have tried using some male hormones with females, the testosterone. I know a few gynecologists that will place one pellet. I mentioned earlier the Testapel, a pellet that's placed under the skin. In a male, we use about 6 of them. In a female, they give them sometimes one pellet that lasts 3 months, and it's just to increase their testosterone. It sometimes helps to increase their libido, helps their with arousal. But of course, it's controversial because sometimes they can develop some of the male characteristics. They'll grow more facial hair, and that bothers women, and it doesn't make the men very happy either.
Probably
then
not.
Then there's ADE. ADE is supposed to be again a non-hormonal that stimulates female arousal, but it's got a lot of side effects. And the biggest problem is you can't take any alcohol when you're on it. It's a daily pill that you have to take, but you can't have any alcohol when you're on this medication because it could drop your blood pressure and patients have fainted. So it's got some nausea and fatigue and dizziness. So it's not a great medication in my mind. There's another one that's called Valisi. That's an injection that you take right before, but it's self-injected before anticipated sexual activity. Again, it's non-hormonal, but it's supposed to help with arousal. We've even tried using Viagra in females. It really hasn't done much very good. Hasn't had much effect. So it's a subject that there's a lot of interest on. A lot of women do develop female sexual dysfunction, especially the hypoactive sexual desire disorder that we just talked about, HSDD. But we don't have as many simple answers as we do with the male, because in the male, we just have to simply help them to have an erection.
Okay, so we hear from others that there are certain creams that they could use on their vaginas, on their clitoris. One being called Scream Cream, and I don't know if you've ever heard of that, but it makes them scream, I guess. But is there anything else holistic that you know that can be used?
Some of these creams I think are simple. I mean, I don't know what's in Screen Cream specifically. I've heard the name before, but I think it's sort of like a mentholated cream that's just a stimulant. Like to create some of that tingling sensation that you get with those types of creams. That might be alcohol based or mentholated, but sometimes they'll use hormonal creams. They have used, again, we use the estrogen vaginal cream in patients with atrophic vaginitis. What happens is, as women have gone through menopause, the tissues start to shrink. They don't lubricate. They lose their vascularity. And so we use an estrogen vaginal cream. They use it 3 nights a week, and they do it before they go to bed. I tell them to use a fingertip method so they don't waste it. They put it on their finger like toothpaste, and they put it inside the vagina, smear it around, and they go to bed. And it takes a couple months, but eventually the tissues do get healthier, and it helps, especially in patients that have pain with intercourse, that it's uncomfortable because it makes the tissues thicker. With atrophy, the tissues get very thin, and it hurts more to have sex.
Okay, thank you. So there's a person that online, just one person so far has asked a question, and this person is the icebreaker. I'll say that she is female, and that's it. And I'm asking, and I'm hoping that everybody else starts asking questions as well. So this person wants to know, in women who are unable to orgasm, is this due to nerve damage, and can it be reversed?
So the female orgasm is complicated, as I have said, and it could be any number of things. Particularly in an MS patient, I think we have to think about the neurological being probably higher on the list than some of the other things, and due to loss of sensation, spasticity, it can be neurological, and unfortunately, that's not something that I have any specific treatments for as a urologist or urogynecologist. We don't have anything specific for that. But if it's any of the other things that I mentioned, whether it's hormonal, or if it's more if it's relationship based, and they might need to see a sexual health therapist, there's other options there. But it really is so complicated, and we try to just cut things down the list. Go through the list. But with a MS patient, it's more likely to be neurological that they're having a problem.
Okay, thank you for that. What can you tell us about the women that have pain and that keeps them from wanting to get involved with sexual activity? Pain from having sex.
Right. Again, we usually think it's due to maybe some vaginal atrophy. The thinning of the tissues. So we would start most women who have pain with intercourse on a estrogen. I use estrogen cream. I like to use the creams rather than the pills because I'm trying to avoid the systemic effects. There is some concern that some of these hormones can increase the risk for like breast cancer or uterine cancer. So we try to limit the amount of blood levels of the estrogen. So we're using the estrogen cream on the vagina to avoid the blood levels. You don't get much absorption into the blood with the estrogen creams. Women that have had breast cancer are very concerned about taking any kind of estrogen. But over the years, we've been sort of convinced a lot of the oncologists and the patients that using an estrogen cream is not going to increase their risk for having recurrence of the cancer because it's not even detectable very much in the blood. It's really very minimal. So that's probably number one that we use for pain. Other than that, it's lubrication. Patients need to have adequate lubrication. The ones that I recommend, well, there's a good vaginal moisturizer called Replens, R-E-P-L-E-N-S. Replens is one that's easy to find in most pharmacies. The one that I like better is called Hyalogyn, Hyalogyn, which is hyaluronic acid. Hyalogyn, you usually can find on the internet. It's a little more expensive, but it seems to do better as a vaginal moisturizer. And then the tissues, it can be used as a lubricant too. There's many lubricants out there, but it's mostly as a vaginal moisturizer to help those tissues to heal up and not be so dry.
Okay, so getting into what you're talking about with the dryness, there are medications like such as Detril or Memory-Cognition and others that are known to dry a person out. Doesn't this also affect their ability to get wet during sex? And if yes, what other sexual lubricants might be available even holistically to get wet or lubed up?
Well, that's a really good issue. I've not heard of that. Certainly, these are anticholinergic medications, antimuscarinic medications that dry your salivary glands. They dry your eyes. They make your bowels slow down, so you get constipation. Unfortunately, that's a major side effect to these. Whether or not they decrease vaginal lubrication, I've not really come across that. I don't know if that's true or not. It makes sense that it probably would, but I don't know if anybody's looked into that because usually the dry mouth and the constipation are so much more bothersome on a day-to-day basis. But I would imagine they would be drying. So I would again refer patients to use these lubricants that are available easily, and to use a vaginal moisturizer.
Okay, great. Thank you for that. So a person just responded that DHEA vaginal capsules, which are compounded and are safe as the vaginal creams. And do you know about that? Are you familiar with it?
Well, I use DHEA in my male patients. I don't know about female, but again, it goes back to the concept of using androgens. I mean, testosterone is the #1 androgen that we talk about, but DHEA is a building block that we use to make testosterone. And so some of my male patients that have low testosterone, I tell them to take over-the-counter DHEA. It's available over-the-counter, 50 milligrams, and it just provides them a building block for making more of their own testosterone. And it seems to have some androgenic properties in and of itself. So using it in a female makes kind of sense. It would be a little bit, it's a mild androgenic, and it probably will avoid some of the side effects that taking testosterone itself would be for a female.
All right. So thank you for that. Why is it that females have such a difficult time reaching orgasm?
I think every man wants to know that answer.
That's very true. It's very, very true. But my next question is going to be more difficult than that, so you better stick with this one.
Okay, well, why?
Time for you to start
Women are
getting
complicated.
nervous.
What can I say? They're complicated. I think in some women it has to do more. It's not so much necessarily physical. I think there's more of a psychological, emotional component, and I don't know the answer. I don't.
Okay,
I think women can certainly test themselves. They should think about masturbating and using a vibrator and seeing, is it something that's more physical, or is it more psychological or emotional or relationship based? If they're able to reach climax on their own, I think that means that everything is in working order.
Right? Just an excuse not to have sex with their significant other, right? All right. Going further, for those females that do ejaculate, some women think that they squirt a small amount, or guys alike, is actually like urine. There are some women that don't think that they're having an actual orgasm. They feel that they are leaking this liquid, again, squirting, it just flowing out of them or whatever, and they're embarrassed. And it causes them to be very embarrassed about it, because they don't know that it could be an actual orgasm, and instead they turn it into that they feel that they're urinating while they are having sex. What can you tell us about that, to make it less embarrassing for women, or whatever, with this so-called squirting issue?
So what I just recently learned is that there's a difference between female ejaculation, squirting, and incontinence. Apparently this is just sort of come to light recently. But ejaculation, they think, is coming from the Skene's glands that are attached to the urethra, and that during arousal and climax, a white milky fluid will come out through the urethra. And it might have a little bit of urine, but it's mostly from the Skene's glands, and that's the ejaculation. Squirting is thought to come a little bit higher up, and there might be more urine in that component, and that's again related to arousal and ejaculation. But the incontinence is just the urination. So if I can't tell you that ejaculation or squirting are pathological. Those are something that is I think very individualized. Some women do it, some women don't, and whether or not it's probably just a normal function. But in terms of incontinence, these patients probably might have to pre-treat with something to prevent the incontinence. If they're leaking urine, if they know it's urine, if it's because the other fluids don't smell or seem like urine, but if they're having incontinence, they might have to pre-treat with something like Sudafed. Sudafed or is probably the easiest one to get. It's over the counter, and what it does is it tightens the sphincter. It helps prevent some of the leak. If they're prone towards an overactive bladder, they can also use, the medications that we have already addressed, Detrol, oxybutynin, or Merbitric. But there's one in particular that I use when patients are having incontinence and it's not directly the bladder, but it's more the sphincter. It's called imipramine. Imipramine is an old-time medication that we use in still to this day, we use in children that wet the bed. And what it does is it does relax the bladder, but it also tightens the sphincter muscle, so they're less likely to leak. And so I would think that would be a good choice of medication for these patients who are having incontinence during sexual intercourse. But the problem with imipramine is that it takes a while to kick in. You got to take it on a regular basis. And it just still does have some dry mouth and constipation associated with it. It was originally designed to be an antidepressant, but for depression, we used to give 300 milligrams. For incontinence, we use only 10 or 25 milligrams. So it really doesn't have any effect that way.
Okay, great. Thank you for that. By the way, everybody, I know the doctor's been spelling out a lot of things for you, and I don't expect that you're going to have written that down really quick. So just know that this program will be on our YouTube channel in just a couple of days, okay? And Doctor, you mentioned Sudafed, but won't that make the person a little jittery? And then, they're going to have other issues going on with that. So, but better than Benadryl, right? Because Benadryl will just put them to sleep, and that'll just cause more problems.
Right. Well, Benadryl is antihistamine. Sudafed is an agonist. It's like ephedrine or pseudoephedrine. It's an agonist. So therefore, it's not the same thing as Benadryl. Benadryl is antihistamine. This is a decongestant.
Right.
Sudafed's a decongestant.
Okay. So going back to the actual the amount of wetness, whether it's squirting or otherwise, it's best to know though that unless there's an odor with it, it's actually a good thing, and that it's not urine related at all. And so the person could be extremely happy.
It's not pathological. It's normal. It's a normal function for some women. Not all women obviously do this,
right?
But it's not considered It's not abnormal.
Okay, thank you for that. What is the difference, or is there a difference between clitoral orgasm or vaginal orgasm in women? And can all women achieve one or the other, or both?
I don't know.
Okay.
That is a huge topic that I don't know if we've really resolved. There's so much that we don't know, and I'm not going to be able to answer that one.
Okay, well, I thought you might be able to answer that one. All right. Next, going back to getting a person to be more active in their sexual life. I mean, I would think that women who don't feel that their man is just after them for a piece of something, and instead, they're wined and dined, they're taken out for dinner, the woman feels good because they're dressing up to go out and they're having a good time together, and they build an entire intimate evening, to make it very special. Wouldn't that itself even help, as a holistic approach to this whole scheme of things?
That's part of foreplay, isn't it?
I think they call it that. 6-play, 4-play, 2-play, whatever. Yeah.
Again, we're two men talking. If you were to have a woman on the panel here, she would have her perspective, and again, it's still a mystery to me. So, and right. I don't know the answer to that. I wish I did.
So the next time we do this, I have to have a female doctor. All right.
Or a female, somebody with a vagina at least.
Yeah, right. What about dogs? They can't answer us though, right? Okay, next, can you suggest useful tips that individuals might incorporate prior to intimacy, such as, emptying the bladder and bowels, using sanitizing wipes or whatever? I mean, how do you feel that this might help in their sexual encounter?
Um, I'm sorry, I didn't understand the question. Could you repeat that?
Sure, I'll do it in English this time. All right, I'm joking. Can you suggest some useful tips that might incorporate prior to intimacy, such as instead of just getting into bed or on the couch or wherever it is that they do it, but try using the bathroom first. I mean, will that help?
I would think so. I mean, I don't even think that applies necessarily just to MS patients. I think that applies to
Anybody?
just about everybody. Yeah,
Right,
I
to
think so.
anybody. All right. So I'm going to ask the audience, do you all have questions? I mean, I want to be able to ask the doctor what you really want to know. It can't be just what I'm talking about, especially ladies. Come on. There's got to be questions that you might have that I, as a guy, cannot possibly think about. So I need you to please ask some questions. All right. And that could probably help as well. All right. But going back to what you were talking about earlier, let's talk about the sexual dysfunctions again. What are you mentioned earlier the primary sexual dysfunction. Can you just list them again? Because we did have some people come in late and I want them to hear about this as well.
Sure. So I have it.
You have it written out.
I have it written out, so that makes my life easier.
Okay, I just got to look cute for everybody then, so maybe they'll be happy with me just looking good.
Okay, so the primary effects, it's on that brochure, on that handout, by the way. So make sure that you look at that. But the primary effects are related to impaired genital sensation and or decreased sexual drive. Those are the primary ones, and that affects 52% of MS patients. Secondary effects are fatigue, bladder problems, spasticity, or muscle tightness, and that's 37%. And then tertiary effects are related to psychological distress, overall well-being like depression, and feelings of a negative self-image, and that's 41%. So these are high percentages of MS patients that have sexual dysfunction of either the primary, secondary, or tertiary effects.
Okay, so I don't have any questions. I don't even know what to ask about all of this. I actually was waiting for some of the patients online to ask, so I'm hoping that you all can come up with something. Otherwise, I'm going to have to say that we're probably finished for the night. But I did want to ask one other thing, and that is that with regard to the sexual problems have a significant impact on the quality of life and the relationships, where does it seem that there's a loss of connection with the illness, with MS?
So I think I had another number there that showed that a significant number of patients with MS would have the frequency of genital and sexual problems in the studies on MS is between 75 and 84% for men, and between 45% and 85% for women. So huge numbers will have an incidence of sexual dysfunction. And all phases of sexuality can be affected. Sexual problems have a significant impact on quality of life and relationships. There's a high rate of separation and divorce, but it does not seem to be a connection with the duration of the illness. So we're expecting to, that there are problems. A lot of them can be solved. I have patients that have worked their way around issues. Let's say there is a problem with genital contact. They'll still have a very satisfying sexual relationship that doesn't involve genital to genital contact. They'll do other things. There's a lot of room for creativity here. I don't have to tell you, things that can be done, but there's a lot of options. And it really is what makes you feel good. Sex is a way of expressing yourself and showing your partner that you are you want to be intimate with them, you're connected with them. It's really complicated, but sex is not just simply of course we're talking heterosexual. It could also be homosexual, but the point is that it's not just vaginal penile interaction. That there's much more to it, and it's not something that I deal with as a physician surgeon, but the sexual health therapists are very effective in getting patients to understand this concept, that it's not just that.
Okay, thank you. Hey, people responded. They're asking questions. That's great. Thank you very much. All right, the first one, a person writes that there's, as far as lubrication goes, there's also oral lubrication, which, yeah, that's gets a little bit more sexual involved, right? But there is oral lubrication as well. Another person is asking if Scream Cream is only available via prescription. And the doctor didn't hear about Scream Cream, but from what we've heard from Dr. Boster and others, it is available through a compound pharmacy. So you would have to contact a Dr. Boster or another doctor and ask them for a prescription, and then you could go to a compound pharmacy. But there are holistics available, even right on Amazon. They have different things that you can use. So I just want to answer that for that person. All right, now a person is asking.
I just want to caution. There's a lot of snake oil out there when it comes to sex. Let's be honest.
Yeah, but the bottom line is, even if it's a placebo-like, if it works for them, then that's great.
Absolutely,
right.
Absolutely. But I'm referring to things like I see all the time these testosterone.
Lost his sound.
Really going to
lost your sound briefly.
I'm sorry. I was referring to something like the testosterone boosters. There's not much else besides DHEA that's going to boost testosterone in a patient. So, therefore, most of those testosterone boosters are not real. That's just an example of something.
Okay, thank you. All right. Person is writing. I say a person because remember, I'm not saying your names. I want to thank the doctor for mentioning PTNS. I just completed my 12th session and the results have been great. Question: does it matter how strong the current feels when the needle probe is inserted, or do I get results anyway, regardless? Regardless. Oh my gosh, I can't see the rest of the question. Regardless on something. It doesn't say the rest of the question.
PTNS, it has to do more with the bladder. That's a nerve stimulation that patients come to the office and get a little needle placed, like an acupuncture needle, by their ankle, and it affects their bladder. But I didn't mention it as part of the talk here today.
Right. Okay. Next person is writing, how is spasticity different than loss of sensation in the vagina?
Well, loss of sensation is sensory. Spasticity is motor. So that's the most basic division there. And there's not necessarily spasticity in there's pelvic floor muscles that can become spastic in MS patients. I have to deal with that sometimes. But loss of sensation is sensory. That's where they don't have enough stimulation to achieve their climax.
Okay, what is the difference between orgasm and climax? Is there a difference?
Yeah, the orgasm is, I think, they define as something that's technically in the brain. You have there's a dopamine release. There's a sensation. Climax is more in a physical sense, where there's ejaculation or whatever. But that's, I think, how they define the difference.
Okay, going back to the one speaking about PTNS, what I couldn't read was they want to know if the needle probe needs to be in the same place or the same area each and every time.
So PTNS is a posterior tibial nerve stimulation that is a little acupuncture needle that we hook up to a stimulator. They get a half-hour treatment once a week for 12 weeks. And it's placed, we try to place it as close as we can to that posterior tibial nerve. It sort of retrains the bladder. So the bladder, it decreases the urgency frequency.
Okay, thank you for that. Next, another person. You mentioned that Osphena is a new med for atopic vaginitis. Has it gone through the appropriate clinical trials so that it's FDA approved?
Yes, it has been out for a while. It's been out for several years now. But
Okay.
yeah, it's FDA approved. All the ones I mentioned are FDA approved.
Okay, thank you. Another person writes, does pleasuring yourself make it harder to climax when being with a partner?
I don't believe so. I don't think that's necessarily true. I think there's some advantages to learning about what you like and what you need, what stimulates you. And therefore, when you're with your partner, you can sort of tell them what they need, and it'll make it easier for your partner to help you to achieve climax. So I don't see any problems in learning what you like, what helps you.
Okay. Another person writes, what do you know about the Emsella chair for patients that are doing pelvic floor therapy? Is the Emsella therapy recommended?
So this has been, again, this has more to do with urinary frequency, urgency, and incontinence. Mostly, I think, stress incontinence. This concept is kind of old already, and most physicians have given up on it. But it's a chair with a powerful magnet that turns on and off, and you sit in the chair, and it causes your muscles to contract, your pelvic floor muscles to contract. And the idea is that it's like doing Kegels, only you don't have to do the exercises, and you build up the muscles. Most the doctors I know that went out and got the chairs, they don't use them anymore. It's not reimbursed, I don't think, by insurance, and I don't think it's ideal for the MS patients. The problem of course, with MS patients is that it's neuromuscular. Their muscles are not as good. So things like PTNS and interstim and sacral nerve stimulation. Unfortunately, my experience has been it doesn't work as well, or is not as durable in the MS patient as it is in the general population, because I think the demyelinated nerves don't carry the nerve stimulation as well, the electrical stimulation as well.
Okay, here's another good sexual question for you. What if a woman keeps having multiple orgasms and has multiple liquid each time with each orgasm?
This is a problem?
When do they dry out?
I don't know. You got to remember, I'm a virgin. This is all new to me, so I can't answer some of these questions. I'm sorry.
Gray hair gave it away. I got it. All right. Another question. Having tried an estrogen vaginal cream for dryness without success, what is the recommended amount before I should expect to see less dryness?
So the estrogen vaginal cream that I tend to recommend is Estrace. It has it's simpler. It's probably a little less expensive than Premarin. So it's called Estrace, ESTRACE cream. And I tell the patient to use their finger and just squirt just a little bit out, like toothpaste, about maybe a little less than an inch or so, and to sit on the toilet or on the edge of the bed and use their other hand to spread the labia, spread the vagina open, and to take the cream on their other finger and put it inside as deep as they can and smear it around and go to bed. I tell them to do it Monday, Wednesday, and Friday night, which is 3 nights a week, and they have the weekend off. And it takes a few months for it to really have an effect. It doesn't work quickly. It's very, very mild. You don't get blood levels really with the estrogen cream this way, and you're using it sparingly, so you don't waste the cream. It usually comes with a little applicator, and you put that in the vagina before you go to bed, and you squirt that big lump of medicine in. In the morning, you stand up, and the medicine just drops out. It never got used. So I tell them to use a fingertip method instead of the applicator.
So I think if enough people use that fingertip method and they do their own thing, they may never need the cream. Right. Guys, you know what I'm talking about. Ladies, I'm sorry if you didn't get it. Okay. All right. Another question here. We have, do you think a PTNS works better than Medtronic bladder stimulator? Stimulator put in this past June. Not happy with it as much as I thought. Unfortunately, I now know when I have to go to the bathroom. Fast, walk worse when I have that urgency. Think that the nerve plays into it?
So I've done a lot of Medtronic InterStim. I started back in 1999. I've implanted a lot of InterStim. At first, it's not indicated for patients with MS, so it's off label. And my experience has been when I did place it in patients with MS, and we had some initial improvement, but it didn't last. It wasn't durable. I don't know if it has to do with the demyelinated nerves or not, but I was disappointed in the long-term effects of InterStim in MS patients. So, and again, the PTNS is another way of stimulating nerves, and unfortunately, because the nerves are not working as well, I don't think it's a great option. But it's something to consider. It's less invasive, certainly, than the InterStim. But again, I'm not a big fan of InterStim or sacral nerve stimulation. There's another company called Axonics that I like better. But anyway, I don't use that anymore in my MS patients because it's been disappointing.
Okay, thank you. Last question. What do you suggest people use to increase desire for men and or women?
Porn.
Women don't want to hear that. Women really don't want to hear that.
I don't know what to say there. What to do to increase desire? Again, I think you should start with something that is maybe non-medical. Go to a sexual health therapist, or go to a psychologist, or family therapist, or couples therapy, marriage therapy, whatever, and start with that. Because surprisingly, I think there's a lot more issues in relationships because of that, because sex may not be the problem. It may be the problem is in the relationship, and sex is just a symptom of that problem. And if you fix the relationship, the sex will come back, follow naturally. So I think that's where I would start.
Okay, thank you for that. And do you know any resources that people can go to for everything that we discussed tonight? Do you have any resources that you can to label?
There aren't any specific resources. I mean, there's no, there's nothing out there that there's no telethons for sexual dysfunction. Let's put it this way. You can go to your gynecologist or urogynecologist. If you're a man, you could see your urologist. I discourage men from going to these fly-by-night clinics that are not run by a urologist or an endocrinologist. They're just sometimes there's not even an MD involved. But there's these various clinics out there that claim that they're specific for sexual dysfunction. I don't recommend them, but they're only for men anyway. Otherwise, in terms of resources, there's just not a lot. You got to sort of find it on your own. I did include this questionnaire. I think it's useful for you to bring that with you to see your doctor, and he can then, or she can then focus on what is your particular issue. Is it has to do with neurological? Is it bladder? Is it more emotional, psychological? I think that's a good place to start. But resources, I just don't know where to point you. There's really no.
Well, you mentioned earlier. You mentioned recommendations for telehealth on using sexual health therapists. So, can you give us any names?
Sure, I'll give you a name. She's probably going to be surprised that I pass on her name. Her name is Alana Gisson. Alana is Alana. Gisson is Gissen. Let me see. I might even have her website open. I did open her website just so that in case somebody asked. It's actually ALANAGISSEN.com. And she's been a sexual therapist that I refer to my patients to for a long time. You can use my name. She knows me well. And
Wonder why?
well, at one time before COVID, if you must know, I was trying to develop a online sexual therapy website, and I wanted her to do the telehealth before COVID hit. So we kind of anticipated a lot of this, and then COVID hit, and everything just fell apart.
Right. And by the way, I also know a sexual therapist who has spoken in a lot of our programs. Her name is Marilyn Volker. She's out of Miami, and she does not have a website. But for anybody that wants to contact Marilyn, just send an email to me, and you all have my email, because you wouldn't have known about this program if you didn't get an email from me. All right. So just send an email to me, and I could send you her information, one-on-one. All right. And she's a great doctor. She doesn't hold anything back. So we've had her at a lot of our programs. You could actually see her on our YouTube channel. You don't really even have to give her a call. You could visit our YouTube channel and just type in Marilyn Volker, and it'll pull up the talks she's done for us. And her last name is V as in Victor, Olker. All right, and the first name is Marilyn. That's pretty easy, Marilyn. I'm not going to slow it down. You'll see it when we publish this program. Okay, and we're out of questions. All right, so Dr. Samowitz, I do want to thank you for being online tonight. And we actually went to the full time that we were going to be doing anyway. And yes, we could all smile and say, hey, we learned a little bit about sexual health tonight. All right, and what you didn't learn, you're going to have to contact your own doctors and see what they can do for you, or you could visit and see what we've done with previous programs on this in the past, and they are on our YouTube channel. For everybody that is online, we have 3 programs next week, okay? And I don't even know what they are right now. We do have one with an attorney who's going to speak about financial responsibilities for the families, and what's good for the caregivers, and to be to know more about your financial responsibilities and what is needed for in case of illness gets worse, or hopeful not death on your part. So you can come on and hear that. There's also the MS Patient's Voice, which will have another MS patient who does a lot for the MS community through her podcast, and you'll learn about that. And then there's another topic, and I'm sorry, I just don't have it in front of me right now. So I do want to thank Dr. Samowitz again, and I am going to say goodnight to everybody. And don't forget, as the world now knows, if you heard Dr. Boster last night, wear your damn mask, okay? And be safe. Thank you. Have a good night. Bye-bye.
Be well. Bye-bye.
Bye-bye.